Hello there! Today we're talking about the endocrine system. This is going to be a first of a couple of videos. We're going to talk about different endocrine systems in the body, and today we're going to be talking specifically about the thyroid. But first we have to talk about what the endocrine system actually is. The body has two major communication systems, the nervous system and the endocrine system. Unlike the nervous system, which controls the body through direct innervation, the endocrine system uses a system of hormones, which allows the simultaneous control of many cells and tissues. The endocrine system involves endocrine glands which secrete hormones into circulation. The circulation then transports hormones all around the body, and when the hormones are recognized by specific receptors, it causes a physiological response. There are a few classic endocrine glands. There are three in the brain: the pineal gland, the pituitary gland, and the hypothalamus. In the neck, we have the thyroid and the parathyroid glands, which we're going to talk about today. We have the adrenal glands on top of the kidneys. We also have the pancreas, which is attached to the GI tract, and the reproductive organs, which are both endocrine glands as well. Although the basis of the endocrine system is the endocrine glands, we also have organs that produce hormones called endocrine tissues. These are different from glands because they do not secrete hormones into the bloodstream. Endocrine tissues include the GI tract, the liver, cardiac muscles, kidneys, and bones. Even our skin, fat, and skeletal muscles produce hormones and are endocrine tissues. A hormone is a signaling molecule that is secreted by an endocrine gland into the circulation and acts on a distant target cell. Often these hormones are going to be acting on multiple tissues at the same time. The specificity of the action is going to be dependent on if that cell has receptors for that hormone. Hormones can be classified according to their structure. There are three main types: peptide, amino acid derivatives, and lipid derivatives. Peptide hormones are the largest hormone group in the body. They include things like oxytocin, insulin, growth hormone, and follicle-stimulating hormone. These hormones are comprised of amino acids, and they can vary drastically in size. Some are small peptides and polypeptides, and some are even full glycoproteins. Amino acid derivatives are derived from either tryptophan or tyrosine. This includes hormones like melatonin, thyroid hormone, which we're going to be talking about today, and adrenaline hormones. Lipid derivative hormones are derived from either cholesterol or arachidonic acid. These are things like inflammatory hormones like prostaglandins and leukotrienes, steroid hormones, and sex hormones, and these are all lipid-derived hormones. We also have a group of hormones called neurohormones. These are not true hormones since they originate from the neurons and not from the endocrine glands, but they are still released into the circulation to reach target cells. Neurohormones are released in response to electrical signals into a bed of capillaries. The concentration of hormones in the body is going to be dependent on a few things. The most obvious thing it's going to be dependent on is the secretion rate from the originating gland. If there's more secretion, there's going to be more concentration of hormone in the body. This means that when we're measuring concentration, we're also indirectly measuring the secretion rate. But hormone concentration is also affected by hormone clearance. Hormones have a half-life, and so they are going to be cleared throughout the body, and they can be metabolized by the liver and kidney. This metabolism results in the inactivation of hormones. The exception to this is long peptide chain hormones, which can be metabolized by the removal of only a part of the chain. And when this happens, a new active hormone is created. We even have hormones that act like prodrugs, which require metabolism to become active and functioning hormones. Hormones can also bind to plasma proteins, and only hormones that are unbound, called the free fraction, are capable of binding to receptors. This means that the concentration of hormone in the circulation is dependent on the affinity that hormone has for plasma proteins. This is especially important in the case of lipophilic hormones, which do not like the watery environment of the plasma, and so are going to bind to plasma proteins more readily to escape it, which creates very small free fractions. The endocrine system is not a perfect system, and so we often see endocrine diseases. There are two main forms of endocrine disease: too much hormone and not enough hormone. If a disease is the result of too much hormone, it is a hyperendocrine disorder. If a disease is a result of too much hormone, it is a hyperendocrine disorder. There are a couple of reasons why we may see hyperendocrine disorders. One is that our gland is simply secreting too much hormone, but it can also be an issue with clearance when the hormone is cleared from the body too slowly. We also have cases where the hormone is unable to bind to plasma protein, often due to a deficiency in plasma proteins, and this can lead to an increase in the free fraction. A hyperendocrine disorder may also have nothing to do with the hormone at all, but rather a receptor that is too sensitive to hormone. So even if only one hormone molecule is binding to the receptor is reacting as if there were thousands of hormone molecules binding to them. The most common form of endocrine disease is the opposite type though, which we call hypoendocrine disorders. This is when there is not enough hormone. This can come from under secretion, overclearance, or an insensitive receptor. Before we have a look at the thyroid, I want to have a look at the master endocrine gland, which is the hypothalamus. The hypothalamus is actually quite interesting because it is also a part of the nervous system. It is located at the base of the brain and is connected to the pituitary gland, which is a true endocrine gland. The hypothalamus is made from nuclei and axons that surround the third ventricle, a cavity that is filled with cerebrospinal fluid, and it also has a lot of different clusterings of cell bodies. The hypothalamus is the control center of the endocrine system because it's important in regulating homeostasis, and so it manages a lot of input from both the external and internal environment. It is innervated with the brain, and so it receives a lot of information from the brain, but it also has its cerebrospinal compartment through which it can sense the amount of hormones in the body and also things like blood glucose, plasma concentration, fatty acid levels, and salt concentration. It uses all of this information to give both hormonal and neural output. Neural messages are sent through the brainstem to the rest of the body, and hormonal outputs are sent in vesicles to the pituitary, which is an endocrine gland filled with capillaries. The hypothalamus tends to release neurohormones called releasing factors. These tend to be small peptides that are rapidly metabolized by the blood. This means that we cannot measure them in the peripheral systemic circulation. This makes sense when we think about it, since there's actually no reason for the releasing factors to be in the systemic peripheral circulation, since they only need to travel the small distance from the hypothalamus to the pituitary gland. There are two parts to the pituitary gland, the anterior and the posterior. The anterior pituitary gland is where most of the action is going to be happening. Here there is a number of endocrine cells that secrete hormones into the general circulation. There are 5 types, each which produce their own hormones and act independently of one another. Somatotrophs secrete growth hormone and lactotrophs secrete prolactin, which is important in the synthesis and secretion of breast milk. These two are different from the other 3 types of endocrine cells that we see in the anterior pituitary, since they're not tropic. The tropic effect is when hormones that are made at the pituitary work on another endocrine gland, which in turn produces hormones as well. We call these chains axes. Thyrotrophs secrete thyroid-stimulating hormone, which is in the hypothalamic pituitary thyroid axis, and we're going to be focusing on that for the rest of the video. Corticotrophs secrete adrenocorticotrophic hormone, which tells the adrenal glands to produce cortisol. This is in the hypothalamic pituitary adrenal axis, which we also call the HPA. Finally, gonadotrophs secrete follicle-stimulating hormone and luteinizing hormone, which stimulate the gonads to secrete sexual steroids. This is the hypothalamic pituitary gonadal axis. Let's zoom in now on the thyroid gland. This gland can be found at the top of the neck. It's a bow shape and it's made of 2 lobes. We also have the parathyroid glands, which are embedded in the back of the thyroid. These glands are different and they secrete completely different hormones. The thyroid isn't very large, and so in the average person, it can't be seen from the outside. In some cases, it can. This is someone who has a thyroid disorder called a goiter, which is an enlarged and bulging thyroid. The thyroid is made mostly of epithelial cells, which are arranged into thyroid follicles. The follicles have a central cavity filled with a fluid, which we call the colloid, and it's here where the thyroid hormones are produced. Between the follicles are parafollicular cells, which do not have a fluid cavity and produce the hormone calcitonin. Thyroid hormones are our metabolism regulators, and they tell our cells when and how much energy to use. They regulate things like basal metabolic rate, glucogenesis, glycogenolysis, protein synthesis, lipogenesis, and thermogenesis. They also play an important role in growth and reproduction. Basically, every single cell in our body is going to be affected by the thyroid in some way or another. There are 3 hormones that are secreted by the thyroid, but only 2 are called thyroid hormones. This distinction is because only 2 of the hormones, tetraiodothyronine, also known as T4, and triiodothyronine, or T3, regulate the metabolism. The other hormone is calcitonin, but it regulates blood calcium. There are 6 steps to production of thyroid hormones. First, iodine is actively transported into the follicle. Then a large protein called thyroglobulin is formed in the follicular ribosomes and placed into vesicles. These vesicles are then pushed into the lumen of the follicle through exocytosis and stored in the colloid. Then the thyroglobulin is iodized. The iodine is first made reactive by an enzyme, and then it binds to the benzene ring on the tyrosine residue of the thyroglobulin. When the thyroglobulin is iodized, it can become monoiodotyrosine or diiodotyrosine. We call these MIT and DIT for short. The different coupling of these compounds leads to the formation of T3 and T4. As the numbers imply, T3 is formed by the coupling of MIT and DIT, which leads to a compound that has 3 iodines. A T4 is made from the coupling of 2 DITs, which create a compound with 4 iodines. Then the iodinated thyroglobulin is transported back into the follicular cell through endocytosis. In the follicular cell, lysosomes cleave the iodinated tyrosine portion from the larger parent protein, which is then recycled. This entire process is pretty complicated. We can understand it through the acronym 8-ICE. A is for active transport of iodine, T is for thyroglobulin production, E is for exocytosis of thyroglobulin, I is iodination of thyroglobulin, C, coupling of MITs and DITs, and E, endocytosis back into the follicular cell. So clearly, iodine is very important for the function of thyroid hormones. We tend to eat iodide instead of iodine. This is the salt form of iodine. It's important because iodine is actually really rare as a trace element. Iodine deficiency is one of the most common causes of thyroid disorders worldwide and leads to hypothyroidism. T4 and T3 are very interesting, since T4 is actually not a functional hormone. It's one of those pro-hormones that we talked about before that needs to be converted into T3 in order to become active. Interestingly though, despite being inactive, 80% of the thyroid hormones that we produce are actually T4. This makes a lot more sense when we consider that T4 has a much longer half-life than T3. The half-life of T4 is around a week, but the half-life of T3 is only a day. If the thyroid is producing a lot of T4, which is inactive and going to be circulating the body, when our body needs energy, our cells can convert a circulating T4 into T3 and use it. We tend to convert T4 into T3 in the cytoplasm of the cell. T3 acts on most tissues in the body. When it is active at a receptor, those cells increase the mitochondria in amount and size, and increase sodium-potassium pump activity, and increase the turnover of endogenous macromolecules. T3 and T4 are fat-soluble hormones, and so they're mainly going to be distributed among the plasma proteins. At the end of their life, they are deactivated by the liver and kidney by the removal of the iodine. The other hormone produced at the thyroid is calcitonin. This hormone decreases blood calcium levels by blocking the activity of osteoclasts, which are specialized cells that break down bone to release calcium into the blood. So when calcitonin blocks their action, they stop the release of calcium into the blood. Calcitonin also decreases the amount of calcium that is reabsorbed from the kidneys back into the bloodstream, and we're going to be talking about it more later when we talk about the parathyroid glands, which also help regulate calcium. The hypothalamic pituitary thyroid axis is actually fairly simple. There are two extra hormones that are involved, thyrotropin releasing hormone and thyroid stimulating hormone. We start at the hypothalamus. This releases thyrotropin releasing hormone, which tells the anterior pituitary to release thyroid stimulating hormone. Thyroid stimulating hormone does a couple of things. It tells the thyroid to release T3 and T4, but it also acts in a negative feedback loop back to the hypothalamus, stopping it from releasing more thyrotropin releasing hormone. Thyroid stimulating hormone also tells the thyroid to uptake iodine and accelerates the steps in thyroid hormone synthesis. There is a secondary negative feedback loop also involved in this axis. In this loop, the hypothalamus and the pituitary sense the presence of T3 and T4 in the blood and stop production. Let's zoom in on these thyroid hormones. Since they are fat-soluble, T3 binds to the thyroid hormone receptors inside the nucleus. Their main effect is thermogenic. This means that our thyroid stimulates oxygen consumption, which increases the metabolic rate and produces heat. It also enhances ATP production and stimulates the sodium-potassium pump. T3 mainly works around peripheral tissue metabolism, but it also regulates our body's overall metabolism. This regulation happens when the thyroid hormones cross the blood-brain barrier and acts on the hypothalamus to increase sympathetic nervous activity. Thyroid hormones are also essential for skeletal development and bone growth in children. And in adults, it works to maintain bone mass and heal bone fractures. These hormones are also involved in the development of the nervous system, regulating neurogenesis, cell differentiation, and cell migration, as well as the formation of synapses and the myelination of nerves. A deficiency in thyroid hormones in utero can also lead to slow growth and defects in cognitive development. Thyroid hormones also increase the cardiovascular system's sensitivity to catecholamines, which are neurotransmitters which stimulate the heart. We also need a certain level of thyroid hormone to reproduce. Thyroid disorders can affect the fertility of both sexes. In women, particularly, thyroid hormones affect the menstrual cycle, sexual maturation and behavior, ovulation, pregnancy, and even lactation. This can be both because of the direct actions of thyroid hormones on the reproductive organs, but it can also be because thyroid hormones regulate the homeostasis of other things that are needed for reproduction. So clearly, a thyroid disorder is a big deal because the thyroid simply does so much. There are two forms of thyroid disorders, hypothyroidism and hyperthyroidism. Hypothyroidism is a slowing down of the metabolism and energy use and can lead to symptoms like fatigue, memory impairment, depression, hair loss, swelling in the face and eye sockets, an enlarged thyroid and associated rough voice, dry, rough skin, slowed heart rate, weight gain, constipation, diminished fertility, and menstrual cycle disorders and muscle cramps. We see the opposite happen in hyperthyroidism, which is the speeding up of the metabolism and energy use. And so we tend to see symptoms like nervousness and irritability, insomnia, depression, broken hair and fragile fingernails, bulging eyes, and a large thyroid, warm, moist skin, increased body temperature, increased blood pressure, arrhythmia and an increased heart rate, weight loss, hunger, diarrhea, menstrual cycle disorders, shaking of hands, muscle cramps, and muscle weakness. You may have noticed from these lists that the signs and symptoms of a thyroid disorder can be easily confused with the signs and symptoms of a different condition. This can make it hard for us to diagnose thyroid disorders. It can also be hard since the symptoms appear gradually and subtly, meaning someone could have the disease for years before diagnosis and treatment. To help with diagnosis, it's important that we understand the whole clinical presentation and consider the potential underlying causes rather than simply focusing on the acute management of symptoms. Thyroid disorders can come from all sorts of things: physical injury, damage from toxins, substances like poisons, genetic disorders, and congenital defects, but it can also come from inflammation that's caused by infection, autoimmune diseases, nodules and non-cancerous lumps, cancers, and iodine deficiency or overabundance. Thyroid disorders can be primary or secondary or tertiary. Thyroid disorders are primary if they originate from a dysfunction in the thyroid gland itself. Secondary disorders come from dysfunctions in the pituitary, and tertiary disorders come from a dysfunction of the hypothalamus. There are a few drugs that we should also know because they can increase thyroid dysfunction. The most obvious one is iodine oversupplementation, which can lead to an overproduction of thyroid hormone. Another drug to keep an eye out for is amiodarone. This is a drug for arrhythmia, which regulates the irregularities in the heart rate. Amiodarone contains 37% iodine and is quite structurally similar to thyroid hormones. This means it can be mistaken as a thyroid hormone, and this can activate the negative feedback loop and lead to hypothyroidism. The problem with amiodarone is that it can be potentially life-saving for many patients, and so we can't say a blanket no to it. We have to weigh the pros and cons of this medication and adjust accordingly. Another thing to keep in mind is smoking, which can have a profound effect on the thyroid and increase the risk of thyroid disorders or the severity of thyroid disorders, and can also lead to a poor response to anti-thyroid drugs. Let's now zoom in on hyperthyroidism. This is an overabundance of thyroid hormone. This is pretty common in adults aged 20 to 50, women, people with high iodine intake, and can also be genetic. As we said before, the symptoms of hyperthyroidism are things that would be associated with an overactive metabolism, like irritability, tremors, weight loss, increased heart rate, sweating, and an inability to handle heat, hair loss and soft nails, difficulty sleeping, and bulging eyes. It's much harder to diagnose hyperthyroidism in older populations, since they actually tend to have no signs and symptoms, and if they do, they tend to be subtle. This is because for a lot of the symptoms of hyperthyroidism, older populations tend to already be on medications that can mask them, like heart medications. 60 to 80% of all hyperthyroidism cases are Graves' disease, but Graves' disease only affects 1% of the population. It is 10 times more common in women than it is in men. Graves' disease is an autoimmune disorder where antibodies bind to thyroid-stimulating hormone receptors on the thyroid and tell them to produce more T4. The characteristic signs of Graves' disease are eye symptoms like protruding eyes, blurred vision, light sensitivity, and red, swollen eyes. We also see a reddish thickening of the skin, which is associated with a buildup of protein on the skin. Another hyperthyroid condition is a toxic multinodular goiter. This is when there are multiple overactive thyroid nodules, known as toxic edemas. This is caused when a part of the gland walls itself off from the rest of the gland and causes a non-cancerous lump. Since these are overproducers of T4, our thyroid is going to start overproducing T4. Thyroiditis is when the gland becomes inflamed. As a result of this inflammation, the excess thyroid hormone that is being stored in the gland will leak out into the bloodstream, leading to hyperthyroidism. Hyperthyroidism can also be drug-induced, like with excess iodine consumption, or it can come from the overuse of levothyroxine, a drug used in the treatment of hypothyroidism, and we're going to talk about that one a little bit later. Hyperthyroidism can also lead to a number of long-term complications, like cardiac issues and osteoporosis. This complication is because the thyroid is involved in incorporating calcium into our bones. Osteoporosis is especially something to be looking out for in postmenopausal women, since estrogen plays a major role in bone health. Hypothyroidism is more common than hyperthyroidism, and is also 10 times more common in women than it is in men. It is more common in people that are over 60 years old and populations that have iodine deficiency. Hypothyroidism is a risk factor for cardiovascular disease, and there are a few conditions that fall under the umbrella of hypothyroid conditions. One of these is Hashimoto's disease. This happens when antibodies block thyroid-stimulating hormone receptors on the follicle cells and destroy these cells. This initially inflames the thyroid, which can lead to thyroid hormone leakage and therefore an acute hypothyroid attack. In the long term, though, the thyroid is not going to be capable of producing enough hormones, and it eventually leads to hypothyroidism. Hashimoto's often coexist with other autoimmune diseases like diabetes or Addison's disease. One of the defining symptoms are dental effects, like enlarged salivary glands, a distorted sense of taste, gum enlargement, and tongue enlargement. Iatrogenic hypothyroidism is hypothyroidism that develops in a patient as a result of the treatment of hyperthyroidism. And secondary hypothyroidism is when there are deficiencies in the anterior to pituitary that's often caused by iodine deficiency. The good news about the diagnosis of thyroid conditions is that we have a variety of tests that can be used to help us know if a condition is a result of a thyroid disorder, if it is hypo or hyper, the severity of the condition, and any potential triggers. There are three main thyroid function tests. A TSH test, or thyroid stimulating hormone test, is the best way to initially test thyroid function level, and it tends to be the first test that we do, since it tends to be the first thing to change before levels of thyroid hormones change. If the TSH is too high, it means that the thyroid is not producing enough thyroid hormone, and so the negative feedback loop is not being activated, and the pituitary gland is going to keep secreting TSH. This is primary hypothyroidism. If the TSH is too low, then it means that the thyroid is producing too much thyroid hormone, and it is activating that negative feedback loop. But sometimes a low TSH can also be an indication of a secondary condition, where there's an abnormality in the pituitary, which is preventing it from making enough TSH. Another test we can do is a T4 test. This measures the T4 in circulation. We can measure the T4 that is in the free fraction, or we can measure the total T4 in circulation, which is both the free and bound T4. A free test is generally going to be the most accurate representation of thyroid function, especially when we consider the TSH levels as well. If there are low levels of T4 but high levels of TSH, we know that it is primary hypothyroidism, since the pituitary is sending the right signals, but our thyroid is unable to respond appropriately. If there is low levels of both T4 and TSH, we know that it is secondary hypothyroidism, since the thyroid is responding appropriately to the signal it is receiving, but the signal that is being received from the pituitary is wrong. Another test that we can do is a T3 test. We do this to help us diagnose hyperthyroidism, but not hypothyroidism. This is because T3 is generally the last thing that can become abnormal in the case of hypothyroidism. Some other tests we can do is test for thyroid antibodies, TSH receptor antibodies, and thyroglobulin. We can also do radioactive iodine tests. By measuring thyroid antibodies, we can identify the cause of the thyroid problem. This is because thyroid antibodies are an indication of thyroid autoimmunity. Although these are good for initial diagnosis, measuring it after diagnosis doesn't actually give us any clinically important information, and so we can't use it to track the condition. TSH receptor antibodies are overactive in people that have Graves' disease, and it's helpful when we're deciding if we should stop antithyroid medication in these patients. Thyroglobulin is a protein that is produced by normal thyroid cells and thyroid cancer cells. This isn't very effective in the measure of thyroid function, and we actually can't use it to diagnose thyroid cancer either, but we do use it to monitor post-surgery cancer patients. Finally, we do have radioactive iodine tests. In these tests, we have someone take radioactive iodine, as often a drink, and then we measure its uptake. This tells us about the function of the thyroid, but we can also use the location of that iodine to diagnose if there's a thyroid nodule. After we have done tests and figured out what's wrong, we should begin treatment. The first step of treatment is to provide acute symptomatic treatment in the case that there is acute, severe, or potentially life-threatening symptoms. Oftentimes, we give antiarrhythmic drugs for patients that have heart symptoms. The next thing we do is investigate anything that might have triggered the thyroid condition and address it. This is important in the case of viral infections, smoking, and over-iodine supplementation. In the case of nodules and cancers, surgical intervention may be necessary. Surgery can be the removal of the entire thyroid and then taking the replacement thyroid hormone for the rest of your life, or it can be removal of part of the thyroid, and these surgeries are called thyroidectomies. There are, of course, risks to these surgeries. It can damage or remove the parathyroid glands and may damage the larynx, causing permanent or temporary hoarse voices. If the trigger can't be removed, we intervene and address the specific hormonal imbalances. For most thyroid disorders, the first line treatment is going to be pharmacotherapy. Thyroid replacement agents are synthetic forms of thyroid hormones that we use in the treatment of hypothyroidism. Synthetic T4 is called levothyroxine, and synthetic T3 is called leothyronine. Our first choice tends to be levothyroxine. This is a good option since it lasts longer in the body, it has better bioavailability, and is also cheaper. We also have anti-thyroid agents for hyperthyroidism. Hyperthyroidism medications generally take longer to act, and so it's helpful to have some cardiac medications to help manage the potentially life-threatening symptoms while we're waiting for these medications to work. Radioactive iodine solution is taken up by iodine transporters and intentionally damages the thyroid, and this is a common treatment that we have for patients that have thyroid cancers. Thioamines like carbimazole and propylthiouracil inhibit hormone synthesis by blocking the action of enzymes and inhibiting the peripheral conversion of T4 into T3. The onset of action of these drugs is relatively long since it does not reduce the secretion of hormones that have already been produced by the thyroid, and so the effects can actually take weeks to be seen. We tend to use thioamines in patients that have milder symptoms, especially younger patients. Common side effects are skin rashes and GI upset, and we tend to see a major skin rash in the first 6 weeks of treatment. Of the two, carbimazole is generally preferred, since it has a longer duration of action and there's less risk of hepatotoxicity and vasculitis. But propylthiouracil is preferred in pregnancy and in lactation, since it is less likely to cross the placenta or into the breast milk. We can also use strong iodide salts and high-strength iodine. These are different from iodine supplementation since they are available in much higher concentrations. At these high concentrations, we activate a negative feedback loop and stop hormone synthesis. This is a very fast onset of action to these drugs, but that means they do not have long-lasting effects. This iodine block only lasts for a few weeks. This means that it's a really good treatment option for short-term management of a short-term attack or to prepare a patient for surgery, since it decreases the vascularization of the gland and therefore lowers the risk of post-surgical bleeding. During an iodine block treatment, patients need to be keeping their fluids up. So let's put this all together to make a treatment plan. Our main approach for treating hyperthyroidism is T4 replacement therapy, or levothyroxine. The dosing of levothyroxine is based on lean body mass or ideal body weight. We start this dose low and go up as we need for the next 4 to 6 weeks. When counseling a patient, they should know that levothyroxine is best absorbed on an empty stomach, ideally in the morning, an hour before breakfast. But anytime 2 hours after a meal and 30 minutes before a meal does work. It's also important to keep in mind that some, but not all, levothyroxine formulations need to be refrigerated. So it's good to check the specific levothyroxine that the patient has and what the label says. When it comes to levothyroxine, there's also a decent amount of drug interactions that we have to keep in mind. The first and most obvious is, of course, iodine. This can be iodine supplementation or in the diet, which we see most commonly in seaweed and kelps. We also want to steer clear of amiodarone, which we learnt earlier can be mistaken as levothyroxine. Some other interactions to look out for are calcium and iron supplementation, proton pump inhibitors, ciprofloxacin, lithium, high-dose glucocorticoids, estrogens, and warfarin. We also want to keep an eye on older patients that have cardiovascular diseases. For these patients, we want to go low and slow with dosing. This is super important for these patients because thyroid overstimulation can exacerbate cardiovascular conditions and actually lead to osteoporosis as well. We also need to increase the doses in pregnant women since the pharmacokinetics of the drug changes in pregnancy. When it comes to hyperthyroidism, we begin by providing symptomatic treatment alongside starting anti-thyroid medications. There are 2 regimens that we can have someone on. The first is the adjusted dose regimen. In this, we start with a high dose of an anti-thyroid agent and then gradually lower to the lowest effective dose. Another option is the block replace regimen. In this, we have a high dose of anti-thyroid drug alongside levothyroxine, which is that synthetic T4, to keep our thyroid hormones at a normal level. The long-term plan for treatment is going to depend on the underlying pathophysiology and the patient's initial response to anti-thyroid treatment. Often with severe hyperthyroidism or hyperthyroidism that's caused by a physical cause, we may also use radioactive iodine to damage the thyroid or conduct a thyroidectomy. There are also a few complementary medicines that people may use for thyroid conditions. Before we use complementary medicines, it's important that we know if the condition is a Hyp-O or Hyp-Er condition and know if the patient is on any thyroid medications. This is really important since using complementary medicines alongside thyroid medications can lead to excessive stimulation or suppression of the gland and can lead to major side effects. In thyroid blends, there's a few things that we see often. The big one is obviously iodine, which can be listed in the ingredients list as kelp as well, which is a food that is really high in iodine. We want to make sure that the patients that are taking iodine have Hyp-O thyroid conditions and not Hyp-Er thyroid conditions, and they're not on thyroid hormone replacement therapy. Patients also need to be careful of overdose, since overdose on iodine can lead to hyperthyroidism. Selenium is a potentially effective treatment for thyroiditis, thyroid enlargement that is caused by an autoimmune attack. but there's a possibility of taking too much selenium, especially if the patient is iodine deficient. Tyrosine is a precursor to thyroxine, and so it can increase the levels of thyroid hormone in the body. It's important that we're cautious if a patient is already on thyroid replacement therapy, since it can also lead to hyperthyroidism. We also tend to see ashwagandha added to thyroid blends. There's not a lot of evidence on the effectiveness of ashwagandha, but the small evidence that we have is that it may increase the levels of thyroid hormones. But we have no evidence on its effectiveness in patients with severe hypothyroidism or patients who are on thyroid medications, so it's best to steer clear. Let's talk now about the parathyroid. There are 4 parathyroid glands. Each of these are the size of a grain of rice, and they're embedded on the back of the thyroid gland. Despite its name and location, the parathyroid secretes entirely different hormones from the thyroid. The parathyroid glands produce parathyroid hormone, which tightly regulates calcium homeostasis. Calcium is actually the only element in our body with its own regulatory system, which gives us a hint at just how important it is. It's the most important element in our body. Parathyroid hormone acts on the renal, skeletal, and GI systems to increase serum calcium levels, which is the levels of calcium in our bloodstream. The first thing that happens is the calcium sensors in the parathyroid gland sense a decrease in blood calcium. They then tell the gland to secrete parathyroid hormone. The parathyroid hormone then stimulates the absorption of calcium from the bones into the blood. This may be a bit shocking to hear about, but our bones are constantly breaking and rebuilding. When they're broken down, they release calcium into the bloodstream, and when they're rebuilt, they take calcium out of the bloodstream and place them back in the bones. This is the way that we regulate our calcium levels. Parathyroid hormone increases the number and activity of osteoclasts, which are specialized bone cells that break down the bone and replace calcium. Parathyroid hormone also acts in the kidney, stopping the calcium from being excreted and promotes calcium absorption into the gut. It promotes gut absorption by stimulating the formation of a vitamin called calcitriol. Calcitriol is the most active form of vitamin D, which increases the absorption of calcium, magnesium, and phosphate, but it has an extremely short half-life of only a few hours. Calcitriol works slower than parathyroid hormones, so they're handling different aspects of the calcium regulation. Parathyroid hormone monitors the minute-to-minute control of calcium, but calcitriol manages the day-to-day control. The name calcitriol sounds very similar to calcitonin, but they are not the same. They actually work in opposite directions. Calcitonin is that hormone that's secreted by the thyroid gland that decreases osteoclasts and the absorption of calcium from the gut and kidney to make sure the blood calcium isn't getting too high. There is such thing as hypoparathyroidism and hyperparathyroidism. These conditions lead to too much or too little calcium. Hypocalcemia is the term for excess calcium in the blood, and this can lead to bone or organ damage, as well as organ failure, coma, and even death. Hypocalcemia is a deficiency in calcium and can lead to seizures or severe muscle spasms. Primary parathyroidism comes from damage or dysfunction of the actual parathyroid gland. Secondary parathyroidism comes from an imbalance in the elements or a dysfunction of the other processes that are involved in renal excretion. There's also a possibility that there is a calcium disorder that is completely unrelated to parathyroid hormone levels. The most concerning complication when it comes to parathyroid disorders are the skeletal issues, which we're going to dive into more depth on later. But there's also a lot of other symptoms that are present. The first symptom that people with hyperparathyroidism present with is pins and needles, muscle cramps, and spasms. As time goes on, though, there's a diverse symptomatic profile, including seizures, calcification of the central nervous system, anxiety, depression, arrhythmia, changes in tooth shape, larynx spasms, dry skin, coarse, thin hair, acne breakouts, kidney stones and chronic kidney diseases, and tetany. Hypoparathyroidism increases the risk of Addison's disease, cataracts, Parkinson's disease, and anemia. The cause of hypoparathyroidism tends to be damage to the parathyroid glands from injury or surgery, but it can also be a result of an autoimmune attack. Hyperparathyroidism is the most common parathyroid condition and tends to be caused by a benign tumor that is causing overactivity. People are commonly diagnosed with hyperparathyroidism around 50 to 60 years old, and it's 3 more times more likely in women than it is in men. People with hyperparathyroidism tend to present with irritability, insomnia, memory and concentration issues, depression, anxiety, palpitations, arrhythmia, and high blood pressure, GERD and heartburn, kidney stones, excessive urination, decreased sex drive, abdominal discomfort, a loss of energy, fatigue, and a loss of interest in things in their life. We can treat hyperparathyroidism in a few ways. We can surgically remove the overactive parathyroid gland. This is helpful in the case of primary disorders. Once this tissue is removed, we also want to test if it's a cancer, just in case. After surgery, patients will need to take calcium supplements to address their calcium deficiency, and they'll probably be on those for life. People who have life-threatening hypocalcemia will need to be given calcium via an IV. If someone's not experiencing symptoms and has only slightly elevated blood calcium levels, we will instead constantly monitor blood calcium and parathyroid hormone levels. This tends to involve a physical exam, blood tests, renal function, and bone density measurements. We can also use calcimimetics, which are helpful in the case of secondary parathyroid conditions. These decrease the amount of parathyroid hormone that is being produced. We use blood tests to determine if there is a parathyroid issue. We must compare the total calcium levels and the parathyroid hormone levels. If someone has high parathyroid hormone levels and low calcium levels, that's what we tend to expect. It means that the parathyroid is secreting correctly in response to the low calcium in the blood. If you want to determine hypocalcemia, we would have to try another test. If there are low levels of calcium and low or normal levels of parathyroid hormone though, this is a sign that something is wrong since the parathyroid is not responding appropriately to the amount of calcium that we see in the blood. This is going to be hypoparathyroidism. If someone has high levels of calcium and low levels of parathyroid hormone, this is a sign that the parathyroid is responding appropriately. If you're worried about the levels of calcium being too high, we would have to test other things to check what the reason is, since it's likely not due to a parathyroid issue. But if someone has high levels of both calcium and parathyroid hormone, then something is wrong since there is too much parathyroid hormone being produced, and we would have to do imaging studies to try and find the cause of hyperparathyroidism. So essentially, parathyroid levels and calcium levels should be opposite, and if they're not, it's a sign of potentially a disorder. Let's look now at metabolic bone disorders while we're talking about calcium. The term metabolic bone disorder is an umbrella term that we use to describe disorders that are characterized by abnormal bone mass, mineral homeostasis, bone turnover, and growth. Metabolic bone disorders can be caused by a lot of things, not just parathyroid disorders. Commonly, they're also caused by nutrient and mineral deficiencies and hereditary hypophosphatemia, which is low levels of phosphate in the blood. This is because the fundamental underlying cause is an issue with the metabolic processes using calcium and phosphate. The great news with metabolic bone disorders is that once the underlying defect has been treated, the disorder is reversible. The most common metabolic bone disorders are osteoporosis, osteomalacia, and Paget's disease of the bone. Importantly, osteoarthritis and rheumatoid arthritis are not metabolic bone disorders. They are inflammatory bone disorders and have a different cause. Osteoporosis is a disorder of abnormal bone turnover. Bone turnover is determined by the action of osteoclasts and osteoblasts. Osteoclasts break down bone and increase calcium in the blood, while osteoblasts build bone. When osteoclasts are too active and or osteoblasts are not active enough, osteoporosis occurs. This is characterized by a low bone mineral density and a deterioration of the bone tissue. This increases the risk of fractures. A word that you might also hear around this word is osteopenia, which is a precursor to osteoporosis. This is a dwindling of bone density, but not to an extent where it's yet considered dangerous. Osteomalacia, which is also called rickets, is a decrease in bone mineralization. Bone mineralization is the process by which calcium phosphate crystals are deposited and hardened within the bone. And this is what gives bone structure and strength. So someone with rickets is going to have soft bones, and this is often caused by a vitamin D deficiency. Paget's disease of the bone is a disorder to do with bone remodeling. This is when there's an excessive removal and replacement of bone. And this leads to bones that bow, are enlarged, and are weak. We currently actually don't know the cause of this disease. Another metabolic bone disorder is one that is present in someone that has chronic renal insufficiency, and this is called renal osteodystrophy, and this is a form of bone mineralization deficiency caused by electrolyte abnormalities. There are a few steps in the management of metabolic bone disorders. The first is obviously prevention. This is mainly going to be good nutrition with a focus on calcium, vitamin D, and magnesium. But if someone is diagnosed, we want to be addressing the underlying cause. The first thing we want to be doing is identifying the specific bone disorder and then supporting the bone structure. Usually we do this with pharmacotherapy to correct the pathophysiology or slow the progression of the condition. We may also consider surgical or other physical interventions to brace the weak bone, and we tend to recommend the patient do weight-bearing exercises to strengthen the bone. Let's look in specifically at osteoporosis for a moment. Osteoporosis is a fairly common condition, and there are a few factors that could increase someone's risk of developing osteoporosis. This includes long-term corticosteroid use, inactivity, being a postmenopausal woman, smoking, race, BMI, diet, genetics, and alcohol use. To diagnose osteoporosis, we use DEXA scans to determine bone mineral density. This is presented as a T-score, with a healthy bone being over -1 and a bone with osteoporosis having -2.5. Different bones are going to be having different T-scores throughout your body. We generally give bisphosphonates for osteoporosis. These drugs inhibit the action of osteoclasts, and there are two main ones, risedronate and alendronate. Bisphosphonates require a touch more attention when it comes to counseling patients, since they have very specific practice points. They also come in many different dose forms. Let's look at risedronate for an example. This needs to be taken once a month, and it needs to be taken with a full glass of water on an empty stomach. You must be upright while taking this, and for 3 minutes after taking the pill. This is because this tablet can get stuck in the esophagus, and this can actually burn through the esophagus. We also cannot have vitamins or antacids 2 hours around taking risedronate, since they will interfere with the absorption. Another medication someone might be on for osteoporosis is denosumab. This inhibits the activation of osteoclasts. This is a subcutaneous injection that is given every 6 months. This has to be done exactly on time and cannot be delayed or missed, since if the dose is missed, it will lead to rapid bone reabsorption.